Hello, everyone. Thanks for jumping on this evening. We're really excited to have all of you for this amazing session. We've got Dr. Christopher Kleck and Dr. Alan Daniels joining us to talk about big data, predictive analytics, and alignment planning in the degenerative spine. So with that, I'm going to kick it over to Dr. Daniels to get us started.
Yeah, thank you so much. Really appreciate the opportunity. It's an honor to be here, and thanks to Medtronic, and also really appreciate being here with CJ Kleck, who's someone I really look up to, and it's someone who grew up in Colorado and then lived in Portland. He and I kind of have a similar history. I work with one of his star fellows, Aaron Curris, so real honor to be here with him.
Yeah, same. Excited about this. Thanks, everyone. I know he's going to jump into the talk, but at least wanted to say thank you, and hopefully we can answer some questions today.
Yeah, so the history of surgical planning has come an unbelievably far way. Even in my relatively short career, I witnessed the people I train with still using paper tracing, cutting. The quality of x-rays was extremely poor, and you basically had to guess your correction. Then we started using Photoshop and very primitive computer programs. And here we are today using automated measurements, 3D analysis, and even AI. And it's just unbelievable where we've come in the last 5 to 10 years. The real question is how AI can help us perform better spine surgery. These are three separate papers, two of which are review papers, but are really interesting to show the explosion of machine learning in orthopedic surgery and in spine in particular. And we know AI can do things like cluster types of deformities and try to assess who's going to do well. But I think the real question for tonight's talk is how can AI be used on the front lines by surgeons to help plan and implement the surgeries? So when you talk about AI and patient-specific rods, I will tell you I personally had resistance initially. I always said, well, I like bending rods. That's really the art of the ASD surgery, adult spinal deformity surgery. And I said, they're just really expensive. What's the point? But over time, I've recognized it's a unique way to pair industry with the surgeon where we can really work together in a meaningful way. And you can use the data to help not only plan the surgery, but then to understand your own surgical performance postoperatively. And I think just like an athlete watches video of how they perform in surgery, I think we should be very critical of how we're doing surgically. And this is one way to do it. The unit ASI ecosystem, for those that don't know, it really is a concierge service. I will tell you that one of the most important things it's done for me is to improve my own workflow because some of the work is shared by the representatives who help simulate my surgeries, measure the x-rays. AI is then used to power the models and uses predictive analytics to help plan your surgery to say what is the alignment and what should it be, and then they send you a patient-specific implant. In terms of the predictive modeling, they're able to try to assess how the remainder of the spine will behave after your fusion. I know Dr. Kleck will be talking about that some, and I'll show some cases. And there's a positive feedback loop. So the idea being you plan the surgery, get the rod, do the surgery, then assess the data to see if you achieved what you thought you were going to achieve, see if the patient's spine reacts in the way it's supposed to, not only for that individual patient, but for your whole population. This is just a quick example of what the outputs look like when you say, what's the surgical plan? You look at the bottom left, pre-op x-ray, what's your plan? Post-operatively, did you achieve it? And then the analytics on the right of, what do the numbers show? In terms of true clinical benefit, I will tell you that, and I've seen some data also out of Colorado, they talk about some different true clinical benefits in terms of alignment. I would mention that there's preliminary data that there's probably lower rod fracture rates. I will tell you, I believe there's lower rod fracture rates, but this is just coming out. We have to recognize that patient-specific rods haven't been out that long, and especially with surgeons now using 4-rod constructs and a lot of complex, rod failures take longer to occur. And so it does look like as we follow these patients more and more that there probably are lower rod fracture rates, probably due to less intraoperative manipulation of the rods. I want to briefly talk about my own experience. I think it's valuable to understand where I've been. I will mention that the system took time to build, meaning it doesn't just happen overnight where suddenly you have patient-specific rods showing up at your doorstep. I personally have representatives that have direct access to my schedule and packs, so I don't have to manually send them the images. They simulate the surgery based on my booking form. So I book the surgery to say L3 to S1 fusion. Then they say, with interbody. I tell them what levels, and then they plan it out with the amount of correction, and I approve or modify the plan. And I will tell you, subjectively, pure level 5 data, I believe my OR time's faster. I like to pull the spine to the rod, so it helps me assess if my correction has been obtained, meaning if the spine fits the rod, I know I did it. And as I said, not only is there data that there's lower rod fracture rate, I believe in my own practice I have that, but my numbers are relatively small, so I can't prove it yet. But over time, I think we'll be able to, especially with multi-center studies. So my initial cases all look like this, and I realize a lot of surgeons don't do this kind of work. And so this is where I said, oh, patient-specific rods, this will save time, it'll help me get correction. And this is not where I found necessarily the rods are absolutely most helpful. Because over time, I've done 261 cases, at least by the time the data was pulled a month or two ago, and 50% were adult deformity, but 13% were cervical and cervical thoracic cases, and the remainder were degenerative. And over time, I've used analytics to assess how I'm doing on correction. And for one, example, this is a slide just showing all my deformity cases, showing my preoperative PILL on the left, my planned PILL in the middle, and then you see my achieved PILL, which is the pelvic incidence minus lumbar lordosis, is closely matched. You also can carefully assess how much correction you achieve out of your own osteotomies, for example, or your own interbodies, which I find very useful. For example, I used to say, well, I'm going to get X number of degrees out of my T-lifts or my Smith-Peterson osteotomies, and the unit team said, actually, you don't get that. And so although it was hard for me to swallow my pride, I then said, okay, then plan for less. So here's the real research question and clinical question I have for the group and for all of us here, which is, can pre-contoured rods in degenerative surgery help us achieve our goals, and can they help us redistribute the lordosis? And again, I know that the Colorado team is also equally as obsessed with this, but you have to realize that putting the lordosis where it is supposed to be is very important. And I'm just going to explain a couple slides as to why that is. First and foremost, you need to realize that lordosis comes not only from the disc, but from the vertebral body. And so that's the first thing to understanding when you're trying to think about your degen spine, is that the vertebral bodies are not perfect squares or rectangles. In some cases they are, but they often aren't. So first you need to think about what your disc lordosis is now, what you want it to be, and what the vertebral body is. Beyond that, though, is the shape of the spine. So you start thinking about how the disc looks, how the vertebral body looks, and how the shape of the spine is related to the pelvic incidence. And so very generally, I would just say that there's different types of spinal alignment, often known as the Russelli classification, and what many people are using right now. Although alignment, the one reason that a lot of degenerative surgeons get frustrated is that it seems like the alignment world is a moving target. There's the Schwab classification, then Russelli, and then there's the modified Russelli and all these. But generally, I don't really want you to think about that. At least that's not what I think about all the time. I don't always think this is a type 1 Russelli. In fact, I don't talk that way or document that way. I document how much lordosis there is, how high the pelvic incidence is, and generally, you can think that a low pelvic incidence does not need as much lordosis, and the apex lordosis tends to be lower. A higher pelvic incidence tends to have a higher lumbar lordosis, and the apex lordosis needs to be higher. And I'll talk about why that's important in a moment, but it really is important when we start thinking about what degen surgeons see in terms of their fusions. And I will tell you that I have created many cases of flat back over the years that I look back and go, man, maybe I should have done something a little different. And I think custom patient-specific rods have changed that. So here's one study as to why I can just tell you that the distribution matters. This is an International Spine Study Group study that simply said that if you move the apex of lordosis too high, there's higher rates of junctional kyphosis or junctional failure. And in the degenerative world, it's probably just going to be a little herniated disc or a little spondylolisthesis or a little facet hypertrophy that leads to early stenosis. But the idea being, you need to be careful with things like laterals and prone laterals if you're putting too much lordosis too high. So I want to show a few cases. I think that's generally the best way to learn. I think that that's the most valuable for tonight. This is something I want to highlight, that I'm generally not a surgeon who does minimally invasive, I would just mention, but I am a true believer in it. It's mostly just my own skill set. I recently started using Mazor on a limited basis, in that I still use freehand screws for open surgery. This gentleman, 61 years old, really minimal back pain, but terrible leg pain related to this severe foraminal stenosis. And to me, this is a prime indication for a more minimally invasive approach. To fix foraminal stenosis, I think that interbody work is key, and whether if you are able to achieve it from the back, that's fine. I'm better at doing it from the front. So the most important thing I want to mention is that the unit platform is not so much mandatory for me to get a rod that fits so I can do this surgery, because I'll tell you the interbody work is what is able to correct both the alignment considerations and the foramen. But the entire platform, start to finish, is what helps me measure the patient, plan the surgery, implement it, and then follow it afterwards. And it's all in my workflow that I use for every single patient, so I retain the data. So he got a 2-level anterior lumbar interbody fusion through standards mini open approach, and then percutaneous screws with Mazor, and went home post-op day 1 doing great. And I've recently seen him back for 6-month follow-up, and he's back skiing, actually. How about slightly more complicated cases? And so, yet again, I think measuring her is extremely important, recognizing that you've got to do your best to put her back where she belongs if possible. And understanding not only from the unit system of where she lives, where you want her to be. And so she got an open interbody fusion with posterior interbodies. And you can see that really drastic improvement in terms of her SVA and overall alignment. And so has done very well. And I would say the rods, for this type of case, it is nice to have a rod that's bent in the appropriate manner. And you can really see the postoperative rod versus the plan is highly similar. In terms of isthmic spondylolisthesis, this is grade 4 spondylolisthesis in a young patient, 17 years old. You can see that she has a very challenging problem because of the angle of spondylolisthesis. And you're going to see, I'm going to go through quickly, but a lot of slides in terms of my surgical technique, because I think that this is a very challenging surgery. The anterior approach is hard because of the angle. The posterior approach is hard because of the angle and because it's hard to reduce it and get an interbody in there. And so there's no easy solution, but you really would like to get her reduced at least some degree, and you'd like to correct the angle so that she has some lordosis at 5-1, which is very challenging in my hands through a posterior approach. You can see that she's developed severe foraminal stenosis with the isthmic spondylolisthesis, so she's open in the back. Overall, though, these young patients tend to have a very nice, normal-looking EOS film from afar. I on purpose did not zoom in on this, that the average person may look at this and go, oh, this girl looks beautiful. But she's not. She's got a terrible focal deformity and compensates well because she's young. Yet again, so measuring her parameters out, you see the rod is not terribly lordotic. That's okay. You recognize it's a huge correction, that it's largely correcting the slip. I want to show a couple quick slides that I did do this to the front. And the key for me anyway is using a curved cob to get it into the space. It's all the way down on the pubic symphysis. This is a standard fan and steel incision. Get it back there carefully, not to disrupt the end plates. This is my initial ALIF, and it's pretty ugly in terms of the amount of slip correction, the location, it's oblique. The whole thing just didn't make me feel too good. So in my hands, I did not want to fuse L4-5 because I think the L4-5 disc is healthy. I do personally think iliac screws are mandatory for me. I ended up showing this case on LinkedIn at some point, and all the European surgeons said I was a monster for using iliac screws. But I will tell you, I had one 17-year-old kid who I did not place iliac screws, and he recurred, basically broke right through the sacrum, and it's a very hard problem to fix. Because the cat was out of the bag, we kind of waited a while, and suddenly it's almost like I didn't do surgery. So anyway, I was able to get her reduced all the way, and I just told everyone before, I saw a 9-month follow-up today, doing great. I would mention, I'm not going to go through this case in detail, but unit can be helpful for cervicothoracic case, cervicothoracic deformity. They're able to template up to the occiput, and I actually really like them for C2 to T2 cases and things like that. I even use them for simple things like C3 to C6, although I'll be honest, I don't think they're terribly useful for that, but I like it because my information goes in the hub, and a case like this is just great because I know I got her corrected if it fits. I want to mention one other topic, and this is just one of my research interests, so I won't take too long, but I think understanding what's going on the axial plane is important even in short segment fusions. This is a complicated case of a kyphoscoliosis, low PI patient that you just see, this is incredibly stiff. And I actually ran this case after I did it by a bunch of friends of mine. who said, "Oh, I would do laterals on it and I would do T lifts." And I said, "I think you guys are insane. I don't think you can move a case like this." Well, let me rephrase that. I can't move a spine like this through many means, except for through segmental correction with screws and rods. But that's me, and maybe through some little T lifts to try to loosen it up. But these osteophytes are incredibly stiff, and so I just would like to mention that this was the unit plan, because I think this is what a lot of other surgeons thought too. They said, "Listen, we're going to get a little correction through every level," and what I would tell you is, A, the lordosis is not low enough, in my opinion, and B, I can't get that much correction through those levels. So I hate that plan. But this is good. This is the whole point of it. This is why you work carefully with the team. We revised the plan. I told them I wanted to get most of the correction through an ALIF at the bottom because I know I could. And plan my UIV based on the rotation profile of the spine to see where the scoliosis ended, and chose a hyperlordotic ALIF at the bottom with just screws and rods on the rest of it. And so far, he's a year out and doing well with no PJK. And so I believe that I'm happy with, I'll say, me and the unit team working together to determine, what's best in my hands. Because another surgeon might have said, no, I'm going to do all the laterals and it'll look good. For me, a hyperlordotic ALIF is the way to go, because I could just jack up all the correction in one surgery and then take care of a stenosis with a laminectomy and put screws and rods in. So for me, the benefit of these patient-specific rods is essentially in the planning. And because I am a degen surgeon who also is interested in deformity, I'm really interested in lordosis redistribution, the apex location, and the amount of posterior translation in these constructs. And so I can kind of use the simple plan for just a 3 to 5 fusion, 3 to 1 fusion, to keep building my data, number one, and number two, to try to implement these as well as I can. I'll say that this ongoing surgeon feedback is really invaluable, and definitely less intraoperative rod contouring and notching is really important in deformity. And I would say T10 to pelvis, probably less so for the lumbar degenerative population. With that, I want to just thank everybody again for taking the time, and I'll be passing it over here to Dr. CJ Kleck.
Perfect. And I think we'll be transitioning the slides here. So again, thanks for having us, and very excited. That talk was fantastic, because I'll tell you that Dr. Daniels' talk mirrors our own experience, which was that unit rods were initially really brought in for deformity cases. And so the only time I ever used unit rods was in deformity cases. That's the only experience I had, is for the first about 3 or 4 years, I think, of utilizing these. And so while we were early on, and we're definitely early adopters here at the University of Colorado, it didn't even cross our minds to utilize these in the degenerative world. And so I think starting with deformity, it helps to build off of why we think these rods were important, why the deformity surgeons are using them. Planning is important. But I think planning is equally important in degenerative spine as well. And I want to start here with a deformity case. This is a case that we ended up doing. And I'll tell you that this case, there's much more to it. Up above this is a PJK, and this patient ended up with double PSOs and a massive surgery. But if lordosis matters, and I don't think it's an if question, I think the studies are showing lordosis matters. The studies are showing that where the lordosis occurs matters. It has to matter not just for the deformity surgeon, it has to matter for the degen surgeon. And I think one of the problems is it's very easy, and even in my own practice, I've done this plenty, where I can take a degenerative L5S1 and I can decompress the foramen, and I can put in an inner body and do a posterior fusion, and the patient feels great, and all the scores drop, and the VAS for the leg and the back drops, and the patient's great. And I just tell them, well, in 5 to 10 years, you're probably going to be back for another fusion. I am done in my own mind with that process, and this case illustrates a lot of this. I'm going to tell you, just so you understand where I'm coming up with some of these numbers. We plan our lordosis based off of our PI, and we do this formula, PI divided by 2 plus 28 equals our lumbar lordosis. I don't think that matters as much, and don't get hung up on necessarily what formula to utilize. But in this case, this patient had a PI of 56 degrees. So if you do half that and plus 28, we end up at 56 degrees of lordosis. So those are the goals. Now, at some point in time, this patient didn't have a T10 to pelvis all in one. In fact, this patient went through different surgeries, and you can almost track by the different inner bodies what they had. They started with an L5S1 anterior posterior fusion. Eventually, they had degeneration above that and got a 4-to-1 fusion. And if you look, the 4-to-1 lordosis goal, let's say 65%, the goal is 36 degrees, but the actual lordosis is 19 degrees. So already this patient, after having initially a 5-1 and then a 4-5 junctional level surgery, this patient is short significantly as far as their lumbar lordosis is concerned. What's going to happen? Well, this is the patient that, guess what? They get the next level, and you can see that. So 3-4 was done. They also got 2-3. Those are actually done at the same surgery. 3-to-1 lordosis goal, 47. Actual lordosis, 27. And then 2-to-1, 53, actual lordosis 35. So now this patient's a 2-to-1 with 53 or with 35 degrees of lordosis. They need 53. You're getting to the point where the only way to correct this patient's spine, especially if they're complaining of sagittal alignment or deformity symptoms, is to get in and do a PSO. And that's eventually what this patient had. I can tell you the rest of the story is that they continue to have some other fusions until they finally got to the point where they're a tendon pelvis and they had a PJK. So the failure of this surgery, or the failure for this patient, was really driven by the lack of lumbar lordosis, and the initial lack of lumbar lordosis was distribution of lordosis L4 to S1. So had this patient started with a surgeon that was thinking about what should the alignment be, not just, hey, can I decompress and get this patient up and off the table and out of the operating room and get them back to life in 6 weeks and happy and ODI improved, but really not just doing that, but focusing on, can I restore the lordosis and restore the alignment? Maybe this patient never needed the PSO. And I think that that's the argument. And I think that's the way that we really need to think about this, not just as deformity surgeons. I think all surgeons who do spine really need to start thinking in this manner. I don't think that I'm the only one that believes this way. And especially if you look, Levesque did this great study and they took a large cohort, a multi-center study of degenerative patients, and they went through and just looked at alignment parameters in those degenerative patients. What they ended up finding was 28% of patients were malaligned after a short segment fusion. And if you go back and read through this paper, there's some talk about what they considered this hidden deformity. And I don't think it's hidden deformity. If you look at the degenerative process is a kyphotic process. We lose disc height, we lose facet integrity, and over time, patients lose lordosis. So the reality is we shouldn't be surprised by the fact that patients are becoming kyphotic over time, because that is the natural history of degeneration. And so I also don't think we should be surprised then that patients have what we call deformity, or what's called hidden deformity, kind of after this paper came out. We should expect that. One of the big problems, though, is if you look, 7% of the patients were actually properly aligned and then went to malaligned after the surgery. So not only is it that we're looking for deformity, but it's also that we're creating deformity when we go through these cases. That really got me thinking. And so I said, okay, we had been utilizing the rods, and I'll give you some, I'm kind of taking the horse before the cart. The process started when we started looking at the curvature of the rods, but to kind of leap forward and show you what, after this paper came out, what we were thinking, we went back and looked at all our unit degenerative rods, and we compared our cohort. So all of our patients that had degen surgeries, and we weren't fussed about whether they had a T-lift, an A-lift, an O-lift, whatever, or L-lift, whatever you want to say. We just wanted to see what was happening with our degenerative population compared to that Levesque cohort. And while I'm gonna make a push that for the rods and the planning, I don't really care what it is that helps me achieve the appropriate alignment. I want to achieve the appropriate alignment. And right now, I think it's the planning, and in that planning, also the utilization of these rods. Whether the rods are driving it or whether it's that I'm spending some time planning these cases, I think it doesn't matter. It's the outcome that really matters for the patients. But if you look, when we went through and compared ourselves to the Levesque cohort, in every category, we were doing better. So patients who had appropriate alignment and we preserved it, 74%. Patients who had inappropriate or malalignment and we restored it, 18%. And each of these numbers is better than the Levesque cohort. Patients that weren't corrected, only 4%, and patients that we made worse, only 4%. So in each of these categories, and especially in the not corrected group, we were actually statistically significant just with the utilization of these degenerative rods and utilizing planning in our cases. I also think, and I am fully on board with the idea that you should learn as you go through your career. And so what Dr. Daniels said, that is exactly how we approach this. I know how much lordosis I can get out of a TLIF, an ALIF, out of any inner body. I know how much I can get out of a posterior column osteotomy or a pediculus retraction on average. So it's no longer a question for me. It's no longer, I think I can achieve 15 degrees at this level. It's the data shows, my own data shows what I can do as a surgeon. So this tool now becomes something that drives you to know what you can do and what your abilities are, and then also what you can achieve in any given case. So if you look, and this was just a different way of looking at that data, but the number of patients that were changed from malaligned to aligned in the Levesque cohort versus in our group, again, our sample size was small, but the reality is that the numbers were pretty significant. And for us, this was an important thing. The rods. So this is really what gets back to it. I was doing more deformity, and the rods were only going in on deformity cases. And we would do these deformity cases, and we'd say, well, we're starting to trust the rods, and we're going to put the rod in, and we're going to pull the spine to the rod, or however you want to think about it. But the rod is the tool now by which we're judging our correction. And I started looking at those rods, and I took those rods and I looked at them in off-the-shelf cases, or cases where you just pull a rod out of anyone's vendor tray. Now, I know no one is pulling a rod out of the vendor tray and maybe not bending it. Maybe you are doing that. Maybe you're using the French benders or the plate benders. But what's interesting, this is a case in which this is a pre-bent rod, pre-contoured rod we use for a 5-1 case. And look at that rod compared to what comes out of the tray. So we found that these rods were significantly different just in the looks of them and in the radius of curvature that was in the rods that we were ordering. And actually, I went back and I've asked this question every time. So maybe there's someone in the audience that will finally give me the answer to this. But the standard pre-bent rods have a radius of curvature of 125 to 135 millimeters. That is across the board. Every industry, every person in industry, or every company, that is what they put in the radius of curvature of their rods. Now, I can tell you based on the data, in fact, I'll show you as we talk about it, the radius of curvature of rods going into the spine, whether it's L1 to L3 or L1 to L4 or L4 to S1, the radius of curvature is much smaller, or the rods are much more curved, no matter what you're looking at, than anything that comes off the shelf. So I have no clue where that came from, but that number is bad. So we went through and actually looked at the radius of curvatures in the rods in patients that we were placing. And what we found is basically self-explanatory. So number one, when we're ordering these rods specific to degenerative spines, the radius of curvature is higher, meaning that the rod is less bent when you get into the spine above L4, and the radius of curvature is lower, and the rod is more contoured when you're going from 4 to 1. So it's really it almost seems obvious, like this is how it should be. But the reality is this also informs exactly what's coming out in all these studies. Where is the apex of lordosis, and where should the lordosis be placed? And if you look at the radius of curvature, so when we look at the average radius of curvature of rods, when we're looking from L4 to S1, 59 millimeters. So again, off the shelf, every company that you look at is 125 to 135. So we're talking about basically a magnitude, or a whole order of magnitude difference between the curvature of the rods that you place in the lower lumbar spine and the rods that you can get off the shelf. And even if you look at the cranial versus caudal, so those where we had upper instrumented levels above that L4 to S1, 105. So again, the rod is more curved. That lower number for radius curvature is just telling us that the rod has more curvature, even in the upper portion of the lumbar spine. And all of this obviously was statistically significant if you're comparing to 125 to 135 millimeters. So in the end, all this proved to me was that the patient-specific rods, again, they may not be the only answer. So I'm not just saying that this is the only thing that matters, get the rods and you're going to have a perfect case every time. A huge part of this is planning and knowing what I can achieve with each of these cases. It's thinking about it. It's thinking about not just the neural decompressions, but how can I achieve appropriate alignment, whether I'm doing a single level fusion or I'm doing a multi-level fusion. And I don't want to be academically dishonest and say, okay, that was it. We started ordering rods. We started planning on ordering rods, and now everything's pie in the sky and we're doing great. The reality is that there was a lot of things that we had to learn through this. And one of the big deals is actually down here. we started realizing we had to utilize what are called these realignment connectors. We use a posted system. This would be paramount to utilizing a sagittal adjusting screw or even using a fixed angle screw. One of the things that we started to understand was that not only does the rod contour matter, but the position of the screw within the vertebra, and then the use of different types of screws, whether it's these sagittal adjusting or in our case, using these realignment connectors. And why was that important? Well, now we're paying a bunch of attention to a rod and ordering a specific contour. But that doesn't matter if if you're using tulips with all of this polyaxiality. You can actually lose a pretty significant amount of the contour in those tulip heads. So you have to either be a very good and kind of conscientious surgeon when you're utilizing those polyaxial heads, or we started switching to systems where we could actually control kind of the screw angle to the rod as well. We're also doing a lot more planning now with cages, and so we can look at a specific amount of lordosis that we want at any given level, and we actually plan that in based on both our history as well as the cages that we know are available and we're utilizing. So I have a bunch of cases, but I also want to make sure we leave some time for some question and answers. But I'll just run through these cases to show you what I'm kind of thinking about or what we're talking about. So 4-5 degenerative spondy. This patient had foraminal stenosis. It doesn't look so bad on that x-ray, but you can imagine on the MRI that we're going to see quite a bit of facet joint buildup and capsular hypertrophy. The patient has disc height loss. They're in kyphosis focally at that 4 or 5 level. So this is a case where you think, hey, this is a slam dunk degen case. All I got to do is a partial reduction or a full reduction, interbody work, clean out the foramen, restore some height, and this patient's going to be happy. This is a case that we planned out with an anterior and then posterior with the rods. And I would be remiss if I don't start showing you some of the numbers and things I'm looking at. Now, this is one of the reasons I love this case is I'm going to highlight PT. So the pelvic tilt for this patient, if you look at the pelvic tilt prior to the surgery, and really all we're talking about, look at the position of the femoral heads underneath the spine, or in this case, how the femoral heads are actually quite a ways out in front of the spine. Look where the femoral heads are after we do this correction surgery, this single level degen surgery. So just by paying attention to alignment in this case, we saw a significant change in the pelvic tilt. The patient was able to relax the pelvis and bring that back into better alignment. And if you look, maybe the numbers don't look too impressive. You go, well, the L1 to L4 lordosis doesn't change a lot. Your L4 to S1 lordosis, actually, it changed a little bit more than we expected. But again, what does this do? Well, it starts to distribute the lordosis again into a more appropriate, or based on the studies, distribute the lordosis lower down in the spine. So in this case, this patient now has 78% of their L4 to S1, or 78% of the lordosis L4 to S1, and they only have 22% of the lordosis from L1 to L4. So we've taken that from 40, almost 40 and 61 to 22 and 78. So we've distributed the curve down lower. The pelvis has relaxed, and all we did in this case was a single level anterior with posterior instrumentation. And I do perk posterior screws on this. So this is perk posterior with an MIS rod. So again, I think that I don't do a ton of MIS cases, but paying attention to alignment, the patient got up and walked and did great, and their neural symptoms were gone because we did the appropriate things for decompression and for restoration of height. But at the same time, also the alignment matters. You can do it from lateral. This is a patient that had an L3-4 isthmic spondy. Same type of a picture. We have significant degeneration. We have loss of foraminal height. In this case, we go lateral and then posterior. And again, if you look through the numbers, in this case, the patient wasn't really compensating through the pelvis. But if you look, we're changing the distribution of the lordosis. We're changing where the curves are going. And again, all of this is driven by just paying attention and planning out appropriate alignment in the rods and appropriate alignment in these cases from the inner bodies. This was a case that was a little bit larger. So this is a patient that had multi-level degeneration, and we're planning out multi-level correction through anterior with the posterior rod. Again, post-op, the pelvic tilt, this one we didn't even plan it to change, but it changed pretty significantly in this patient. So even in these degen cases, patients can start to have compensatory mechanisms that they're engaging, including changes within the pelvis and changes throughout the rest of the lumbar spine. And I know we're trying to get to Q&A, so I'm going to finish up with this case because I want to show that you can do a significant deformity correction in patients without necessarily doing a T10 or a T4 to pelvis. And a lot of it happens to be just by paying attention to some of the neural stuff as well. This patient had, if you look, an SVA of 200. I do plenty of deformity surgery, but I did, for this case, only a 2-level extension of the fusion. So I want to show that just because we're deformity surgeons, or at least we do deformity cases, it doesn't mean every time we're trying to do a deformity correction. If you look, what this patient really had was pretty significant junctional level degeneration and a fairly flat L4 to L5 fusion. And so in this case, the central stenosis, and these are axial cuts through the 3-4 and the 2-3 level, you can see significant facet arthrosis with ligamentous thickening, and you can see that central stenosis. So in this case, in this patient, the consideration was that when she laid down on the MRI, she actually came back into a fairly good alignment. And why do a T10 to pelvis, especially when this patient was complaining mainly of neurogenic claudication symptoms, but at the same time, I want to correct her as much as possible to an appropriate alignment. And I know the 4-5 was a little flat. So we lost some lordosis in that case. And so in this one, 2 levels of, in this case, this was a T-lift that was placed, and we did posterior column osteotomies. We did full facetectomies in the back. She's not 100% reduced, so the 200 didn't come all the way back to 0. But if you look at her post-op at 3 months, we reduced her deformity by almost by 50% from 200 to 94 for an SVA. And this patient actually was doing quite well. Now, maybe people will argue, well, you're going to have to go back at some point in time and do more. And that might be a possibility. But at least for this patient, we paid attention to the neurologic compression. We planned out as much correction as we possibly could through the adjacent 2 levels. And she has done fantastic. And she's now, I think, somewhere around 4 years out. So this is a patient that's doing quite well. And I didn't necessarily give her the full Monty deformity surgery. So I'll end it there. And hopefully some of the stuff that we've shown you guys in the talk has at least spurred some questions. So we're more than happy to answer anything at this point.
That's great, CJ. I think those 2 talks complement each other well. I'm not sure if people can see my chat, but I see them. So the first question is, what made us start looking into lumbar lordosis distribution? The short answer is that there's been some research percolating, of course, in the Scoliosis Research Society about it for years. But for me personally, it's because I realized that I was using pelvic incidence minus lumbar lordosis should be around 10 for a number of years. That's the kind of the way I was trained, and I used it. And then some people said, well, maybe it shouldn't be that way. If you operate on an 80-year-old, you go a little higher. And I was simply just trying to get to around 10 for most patients. And I found that that's not enough, because if you just put the lordosis in the wrong place, generally too high, the patient still has a high failure rate, number one. Number two, their patient-reported outcomes are not always as high. And then number three, the risk of junctional failure is higher. And really the way I figured it out was through deformity of doing pedicle subtraction osteotomies at L2 and L3. The way I was trained was that my senior partner said, no, you should always just do a PSO, pedicle subtraction, at L2 or L3, because it's easier, it's higher, the nerves are pretty resilient, and it's usually above where the badness is, meaning that the person was usually fused flat at the bottom and had a lot of scar tissue. And that's not an optimal thing. So I'll finish with that answer. Unless Dr. Kleck wants to chime in, I can go to the next one in a minute.
No, I mean, I think it's been the same journey for everybody. So I totally agree with you. What I will say is that we did, so we were using these rods. So we've used them really since at the University of Colorado, since they came to the States. So since 2014, we've been using them. So we have a long experience. We changed where we do our PSOs just based on the data that we saw from the rods and from really this database. So we did a lot of L3 PSOs, and then all of a sudden we realized we were creating PJK. Patients' distribution wasn't great. They weren't necessarily happy. So now I would say the primary PSO is either an L4 or an L5 PSO, and it's not easy, but it's right. And so the rods themselves have, and all, not just the rods, but all of this kind of this platform have really changed how we look at the surgeries.
The next question is, what's the process for changing the plan? So I like the term a concierge service, because there are people behind the process. This is artificial intelligence and machine learning, but there actually is a person that helps to plan the surgery. And so it is an interchange between the surgeon and the surgery. There's multiple ways it can be done. There is an app. The Unit app is very powerful that many of my partners use, but I will tell you, I actually, for my workflow, I use secure email back and forth where they are able to pull my plan out of my surgical schedule, email me the initial plan. I then email back comments about rod length, amount of lordosis, distribution of lordosis, rod composition, whether you want titanium, cobalt, 55, 660. They can do transition rods down to 60 to 55 or down to 475 or 35. And so it's just an interchange for me, email back and forth.
Yeah, so I see there's also next questions about the planning, the predictive model, and then the unit has it altered the approach to certain interbodies. So number one, just to piece this together a little bit. So they have predictive models for thoracic kyphosis and pelvic tilt. They say those are for deformity surgeries. I just showed you some degen cases where we actually see pelvic tilt coming around, and we utilize it even in our degen cases. If you change the lordosis, you can see changes, whether it's in the pelvis or the thoracic spine. Now, you don't necessarily have to utilize that. It's just something that we do because we really believe in this hook, line, and sinker. But on the other end, they also have this lumbar. They have the lumbar model now that they're utilizing. I do it a little bit backwards in that I actually utilize the model. So if I look at it and say, okay, if I put 20 degrees at L4-5, what happens to the rest of the lumbar spine? And I actually look to see if there's going to be some relaxation of the lumbar spine, either above or below, which is my expectation. For the inner bodies, 100% has changed. So again, if you go back and look at your own data, and that's one of the huge benefits of this. So every one of those cases, I saw Dr. Daniels has 261. We have the number is over, I think it's over 500, but that's a combined group number of cases. That data is yours, and they'll analyze that. They can give you a significant amount of input into your practice. They can tell you what you're achieving with a TLIF or an ALIF or an OLIF or whatever you want to say. So the reality is then that informs you in the next case. And so I think for both Dr. Daniels and myself and a lot of my partners, the way that they practice is what you'll see is now I can say, okay, 5-1, I want to do a 15-degree ALIF, let's say. And that's because I know that there's a 15-degree cage I use and I get 15 degrees every time I use it. So it becomes very reliable. So it's not a question of, oh, I hope this implant's going to achieve the appropriate alignment. It's because I now know, hey, every time I do this is what I achieve.
Yep, exactly my same experience, which is that I always have loved ALIF, but I have gone even further on an ALIF swing, recognizing from my data that my corrections there are by far the most powerful in my hands. I think I've developed a skill set for being able to correct with ALIF. I say that because I know that there are surgeons that can do a lot through lateral approaches, especially my suggestion would be to try to keep them down to L4-5 and 3-4 from almost all patients, but in terms of major corrections. But my point is that I figured out what I'm good at in my skill set and continue to develop it. And I was a bit humbled by my TLIF data and lateral approach data that it's just not that good compared to my ALIF correction. So I've further emphasized my utilization of ALIF. So then the next question is this useful for the standard posterior lateral fusion without interbody? How do you compensate for screw cascade intra-op as the screw may not sit as a pre-op plan? That's a great question. Super important. In fact, probably differs from what Dr. Kleck and myself do, especially if he's using, a posted system or fixed screws, for example, or sagittal alignment screws compared to my polyaxial screws. So in the first question, what I would tell you yet again is it useful for a standard posterior lateral fusion without interbody? Well, it does depend. It depends because I would tell you it's definitely useful, in my opinion, for your data collection, data analysis, planning. It may or may not help in surgical execution is the reality. If you have a polyaxial screw, as CJ said in his talk, and you just throw 1 or 2 level fusion and throw a pretty bent rod in there, your polyaxial screw head can just tilt. And basically, you may not correct the spine. You may just have a beautiful curved rod in there. So the short answer is the rod itself is not magic, and you've got to use tools to do it. So then that plays in nicely to the second part, which is that you're right. It's super important for your screw cascade, and I think a lot about the depth of my screws. So the point is this: let's say you're doing an L4 to S1 fusion. and you leave your L5 screw quite high, you could actually have a completely straight rod and have 35 degrees of lordosis from L4 to S1 because it all depends on how the screws sit. So you are completely correct that it depends on the depth of the screw and the position of the screw for how your spine is corrected. So for better or for worse, it takes a fair amount of thought into how you're placing your screws to make sure the rods are as helpful as useful, or as helpful as possible and as useful as possible. And that goes for the inner body too, that if you put a beautiful T-lift in and your rod looks just right and your screws are good, but if you don't compress on it appropriately, depending on your technique for T-lift, you may not get the correction you need. So there is an extra step in the process beyond, it's not magic to just put the rod in, especially in degen, super important. If in a major deformity correction, you just lay the rod in and pull the spine to the rod, you may have just hit a home run. But in degen, at least in my opinion, it takes a little extra thought and work to make sure you matched your plan.
Yeah, I think one thing you said that's hugely important, and it again to the idea of the cascade of the screws. I think people forget that both depth and angulation of the screw change alignment, and that whether you're using polyaxial tulips or whether you're using fixed or whatever system you're utilizing, if the screw is parallel to the end plate, if the screw is down towards the inferior end plate, depending on how you put that screw, it totally changes the alignment. It's the same in deformity. So that I think that's something that can't be missed, that people have to understand. And I think the reason we have to understand it is that we're getting more and more technical. I think we're changing from what we consider the art of spine surgery to what we're considering the science of spine surgery. And I love that. And I think if you talk to, I don't know your experience, Dr. Daniels, but I think if you talk to people who are using the Mazor, now you can really start to think about screw depth, the trajectory of the screw medial, lateral to medial, all of those things coming into alignment. And so you can actually plan these cases to the nth degree, which is in the end, it's awesome because your precision, your accuracy and precision with these cases both are going to improve now degen to deformity.
I think that's really well said, the Mazor thing, because I'm still a bit of a reluctant adopter because of my practice and the way I've practiced. But one thing I found is yet again, as he said, planning the screws. Even since I do a lot of A-lift with integrated screws, it's actually pretty nice to be able to plan a screw that's definitely not going to hit the A-lift screw. It's incredible and uncanny how often a pedicle screw will bang into your A-lift screw. And my partner, I haven't done it, but my partner actually knocked out a A-lift cage, being a little careless maybe, but the point is perfectly reasonable mistake that he was just trying to get his screw in and push the thing out, which is a very humbling experience to have happen. And so it actually is nice using navigation or robotics with planning to be able to plan the screw around the A-lift. I'll let Dr. Kleck attack this last and next question here.
Yeah, so I think what prompted, I think it's the initial use of this. To be honest, so first case, it was a deformity. It was a T10 to pelvis. That was back in 2014. What prompted us was that there were these French engineers that came to us and they said, "Hey, we can actually bend a rod to the shape of a spine, whatever shape you want us to bend it to." And we thought that's kind of ridiculous, but sure, why, maybe we'll try it. Maybe it makes sense. And honestly, our thought was, hey, if we don't have to bend the rod in the surgery, maybe that saves some time on the surgery. It's a little bit humbling when you go from that to we use them all the time and it's actually improved our practice and we're well improved in everything. But the reality was it was the idea that we could plan these cases out on a computer system as well. The planning actually came before the rods ever came. And if you just spend a little bit of time planning your cases from deformity to degen, for me, it's the best part about this is I'll show a patient the case and the plan. And then once I show them the plan, the patient now has in their mind what we're trying to achieve. And especially maybe in degen, you say it doesn't matter so much, but when you show that the reduction of the spondy and the alignment and the lordosis, even that actually translates to these patients. And so showing a patient a plan and saying, hey, look, this is what I'm going to do to your spine, and a picture is worth 1,000 words, really.
Yeah. Similar experience. We started in 2019, so we have 5 years behind them. But I initially trialed it on a major deformity case, was very impressed. And I just want to be really specific here about my I will say favorite part of the system is the fact that it makes me more efficient. I'm obsessed with efficiency. I see a lot of patients, I do a lot of surgery, and someone might look at me and say, "Well, you're this deformity surgeon. I'm sure you sit and measure lines all day." The honest truth, I don't have time to do that. I saw 50 patients in the office today. So they measure my films for me, track all of the alignment, and then because I can look at a case and go, yeah, I think that needs a three-level T-lift, but I need it refined a little further to know I'm doing the best that I can do for that patient. And so unit makes my life easier. And I'm going to leave it at that to say, my how it changed my practice, because although it was the first case was a deformity and it helps this deformity surgery be implemented better, in the degen world, it just makes my life easier start to finish. Even though fitting in a rod, I can take a French bender and add a few degrees of lordosis. It's not rocket science. I can kind of look at it and go, hey, it's going to fit. So it's not so much that it magically makes that surgery easier, but in the perk situation or the degen plus situation, I just think it's really nice for planning. The next one is about how much variability in lordosis do you see with T-lift? Oh man, it's a lot. And it is for any surgeon, I believe. And I will let my illustrious partner here talk about his own experience, but I will tell you, I do have a lot of variability in T-lift lordosis, especially, for example, in a case that's like bone on bone and there's very little disc space. And I have foraminal stenosis and for some reason not doing an A-lift. I just know I'm not going to get much more than 5, 6, 7 degrees of lordosis. It's just not going to happen. I just can't get the height to do it, especially since I want to fix the foramen. And so this data is good to show the range, what I've gotten in the past, but the honest truth is that there always will be a variability and ability to achieve lordosis through T-lift, because if someone has a big, tall, floppy disc and I put a huge banana cage or expandable hyperlordotic in the front, you can get a lot of lordosis actually through a T-lift. And I'm not the best at it compared to some, but I've seen people get 20 degrees lordosis in one disc, sometimes more. In fact, my partner, Aaron Curris, is really a big believer in PLIF with facetectomy and, I'll say aggressive compression posteriorly. I've seen him get a ton of lordosis, as much as an A-lift, but in my hands, I'm better at A-lift to do it. So the data has helped me to learn, my own skill set.
Yeah, I'm going to say that T-lifts I've actually gone away from a lot of T-lifts because I can't really determine what lordosis I'm going to achieve in those cases. It's all dependent on how big a cage I place, where I place it. If I place it way up in the front versus if I place it in the middle of the vertebral body, or if it's too far posterior, and I don't necessarily always place it perfectly. So T-lift is, for me, it varied all the time, and I couldn't really reasonably control it. So the two things I love the most now at this point is A-lift, and then I do actually expandable posterior or expandable PLIFs. I find that both of those allow me to kind of dial in the lordosis exactly where I want it to be, and they're both kind of more conducive to what I'm trying to achieve.
That's where Dr. Curtis learned it, and it's great, and it works. It's yet again a lot of this talk, I think, should focus on the fact that this technology helps you to figure out what works in your hands, because you can track your own data over time. Somebody's asking me about my use of robotics and how I incorporate unit and Mazor. So I've already told you I'm a bit of a reluctant adopter. So I'm only one type of robot spine user. I freehand all my screws in open surgery. I am going to, Medtronic might get mad at me, but I'll tell you that I tried using Mazor in degen short open surgery and have decided against it for the time being, because I'm just faster at freehand and I'm safe. So far I haven't had to revise any malpositioned screws for symptomatic placement. So for me, it's not accuracy. But for my partners who've adopted it, they really like the radiation reduction because, they may just not be quite as comfortable freehanding. So in my practice, I use robotics primarily for percutaneous or mini open indications, like backing up the A-lift cases like you saw. And the way I incorporate Mazor and unit is basically planning the surgery with unit and then using Mazor to place the screws so the rod is going to fit. The Mazor engineers are pretty good at it. At this point, it's not a highly integrated system, meaning that although they're working on the engineering for this, but at least so far in my institution, we don't have a clean integration of your unit plan is right there, so that all your screws are placed perfectly for it. They're kind of we're all still working on that to make it really highly integrated, but we certainly are able to plan where the screws go based on the plan. But it's not like it's automatic program. Suddenly your plan's there and your screws are perfect. But essentially similar to the concierge service of UNID, the Mazor people that are there helping you implement your surgical robotic plan can basically take the information with you and help to integrate it all. All right, and I believe that's it for the Q&A, and we are right on time, which makes me happy. I said I like efficiency and I like to be on time, so I love it. I hope everyone learned a little something, and I'm always, just so everyone knows, I'm always free. If anyone ever wants to email me, you can go through Medtronic, or my email is pretty freely available online. You can always email any questions. I'd be happy to answer.
Yeah, I agree. Same thing. Thanks for the opportunity to talk to you guys about this a little bit and maybe step on the soapbox and tell you what I think. But this has been great, and I think honestly, this technology is really for both degen and deformity. And I think the more we can get that word out there, the better. And same thing, at any point in time, feel free to email me and either tell me I'm crazy for what I'm doing, ask me questions.
We all know you're a little crazy, but that's a good crazy. It's good.
Just a little bit, yeah.
Just the right amount. All right. Well, we really appreciate it. Hope everyone has a great evening.
Awesome. That's all the time we have this evening. I want to thank Dr. Daniels and Dr. Kleck for your time, your insights, and awesome discussion on the UNID technology. We truly appreciate your partnership. Thank you so much to our attendees, as well as for joining us today. If you're interested in more education on the technology or want more information, please scan this QR code that you see on the screen for next steps. Enjoy the rest of your evening. We look forward to having you join us for future webinars.